Well, hello and welcome to all of our Acute Delta advisory committees, our ambassador groups, and our community members who have tuned in to hear our bi-weekly update. Today is Thursday, December 3rd, and this is our 32nd virtual community meeting. My name is Deborah Volison, and I'm the Director of Community Engagement for Acute Delta, and I'm joined today by our CEO, Gary Herbst. And as I say before every webinar, these virtual meetings are just to keep you informed and up to date on what is happening at our hospital. We will post the recording of this meeting on our Acute Delta COVID-19 frequently asked questions page, and then we will also put it in our private community engagement Facebook page. Gary, it's always an honor to sit, well, I'm not sitting next to you today, but to be on a webinar with you on these bi-weekly meetings. And this one is kind of, we have some just important numbers, some important information to give. So welcome.
Yeah, thank you, Deb. You look great on the screen, and I can see your beautiful Christmas tree over your shoulder there. So I'm kind of bringing the holiday spirit to what will probably otherwise be a rather sobering community engagement telecast this particular week. So I'll try to sprinkle it with the good news that I can here and there, but I think most folks know that across our region, across the state, across the country, and across the world, that we're definitely seeing a resurgence in the virus. So I'll start out with the numbers, as I customarily do, and I'm looking at my producer here, Maria, wondering which camera should I have the live streaming here, and then I have the recorded. If we could get them a little bit closer like Daniel's doing, that would be good for me. So is that, you got me all framed and everything? All right, perfect.
Yeah, looks great, Gary.
Okay, thanks. So at the state level, and again, all the numbers that I'm going to be sharing with you today are obviously significantly elevated from when we last were together just a couple weeks ago. So we continue to do an incredible amount of testing statewide. We continue to do more and more testing here at the local level. So since the beginning of the pandemic, we've now performed 24.3 million tests statewide. 1.2 million of those tests came back positive. And sadly, we've now had 19,324 deaths statewide since the beginning of the pandemic. That positivity rate, that percentage of all those tens of millions of people that have been tested and tested positive, translates into a cumulative rate of 5.1%. But if you look at just over the last 14 days, which is probably really what's most important to us, what are we currently experiencing? The state now has a positivity rate of 6.9%. Just a few weeks ago, it was down to 2.3%. So it's essentially tripled over just a very short period of time. There are currently 9,365 California residents that are currently in a hospital bed at this point in time. The good news is only 2,121 of them are in a critical care bed, an ICU bed, which represents just a little less than 23%. So a little less than 23% of patients that are hospitalized with COVID are of such a critical nature that they have to be in an ICU bed, and oftentimes when they're in an ICU bed, they're probably most likely ventilated at that point, or intubated on an artificial ventilator. And you'll see that will be one of the bright spots I'll talk about with respect to Acute Delta, is that a lower and lower percentage of patients, while they are requiring hospitalization, fewer and fewer actually having to make it all the way to the ICU. So it wasn't that long ago that pretty consistently a third or slightly more of all patients that were in a hospital for COVID were actually in the ICU. So statewide, that number just below 23%. The 7-day positivity rate, so at 14 days we're at 6.9%, the 7-day positivity rate at 6.4%. What's really interesting is, and it's one of the key metrics under the governor's blueprint for a safer economy, again, his 4-tier colored system of most restricted to least restricted, one of the key metrics was the number of new daily COVID cases that you were seeing in a particular county per 100,000 population. To move from Tier 1 purple to Tier 2 red, you had to have fewer than 7 new cases per 100,000 population over a 7-day period. Well, the state right now is running at 30.2 per new COVID cases per day per 100,000. So at the statewide level, we are now far removed from those less restricted tiers. The entire state, in essence, is now in Tier 1. In fact, 52 of the state's 58 counties are now exhibiting metrics that they've all been classified as Tier 1 purple, the highest restriction. I'm asked often about the ethnicity and the gender of patients that or people that are testing positive for the virus and those that are being hospitalized. And from a gender standpoint, it's been relatively even between men and women, 50-50, although it has kind of ebbed and flowed as this whole virus has over this period. And sometimes men are out infecting women and vice versa, but for the most part it's about even. But interestingly, from an ethnicity standpoint, and this is again at the state level, so Latinos, as the state defines, they account for 58.5% of all infections across the state. So the Latino or Hispanic population has been the majority of folks that have been infected with the virus. But interestingly, they account for about 10% less of the number of deaths that are related to COVID. So 58.5% of all positive cases, but 48.5% of all COVID-related deaths. The other ethnicity group, the second behind Latinos in terms of the infection or percentage of total infections, is the white race. And the white race accounts for 19.3% of all infections, so far less than the Latinos, but the white race accounts for 30.4% of all COVID-related deaths. So in the Latino population, the percentage of deaths is actually lower than the percentage of infected, but in the white population, the percentage of those infected is about half of the percentage that account for the total number of deaths. So just some interesting disparities among the different ethnicities that have been affected by the virus. And then lastly, we now have over 53,000 healthcare workers across the state of California that have been infected. Only 218 of them, though, have actually died of a COVID-related death. And the death rate statewide, meaning the percentage of those that test positive for the virus that ultimately die of that virus, has remained relatively low. In California, it's at 1.6% now, slightly lower than the 1.8% that we've been observing in past months. So that's where we are at the state level. Now moving down to Tulare County, we now have performed 217,000 tests statewide. 21,778 of those folks have tested positive, which is a cumulative positivity rate of 10.1%. So we definitely are still running higher than the state. But again, until just recently, maybe over the last month or so, Tulare County was largely only testing symptomatic patients, whereas statewide you were seeing a lot of patients that were totally asymptomatic and were testing negative for the virus. So the state has always had a lower positivity rate than Tulare County. And unfortunately, we've had 314 Tulare County residents that have died of a COVID-related condition, and about 120 of them were nursing home residents. So that number, the number of deaths associated with nursing home residents, has remained relatively unchanged over many, many months. So definitely in the very early months of the pandemic, that's where we saw really the majority of deaths occurring. But fortunately, that has really stabilized, and it definitely is a reflection of the nursing home industry reacting, definitely adopting protocols around personal protective equipment. It's now state mandated that nursing home employees and patients are routinely tested now for COVID to make certain that there are no outbreaks that occur. So kudos to them for embracing that. The 7-day positivity rate for Tulare County sits at 7.4% right now, which, if there were no other metrics involved, that actually is below the 8% threshold that would allow Tulare County to move from purple to red, where we could once again have in-room dining in restaurants, and the lifestyle center could open back up, and schools and churches and things of that nature. So that number has definitely been creeping up. So at 7.4, it is higher than what we've seen. But that's a good thing. And then with respect to the number of daily new cases per 100,000, that's really what's kind of dogged us, since that blueprint was put in place. We are running at 21.5 new daily cases per 100,000 population. So we need to be at 7 or below. So at the 21.5, we actually are doing better than the statewide average of 30.2, but clearly we're 3 times higher than where we would need to be to lower that rate. And remember, the more and more testing we do, that has a profound effect on the positivity rate, but doesn't really affect the daily new cases, and actually can kind of work against you, because it's quite possible that you now start detecting a lot of people that are infected that are showing no symptoms whatsoever and really didn't need to get tested, other than maybe peace of mind, maybe because they've been exposed or their employer's requiring it, but you could end up identifying a new positively infected case that just wasn't exhibiting any symptoms. So that's where we are at the county level. So now at Kuya Delta, and speaking just to the Acute Medical Center in downtown Visalia here, we continue to be an incredibly busy hospital. We are at 94% occupancy as of this morning. Again, that's our adult occupancy, and that's across the entire medical center, the Mineral King wing, the Visalia wing, east expansion, west expansion, the 400 and something acute care beds, 321 of which are, when I talk about that occupancy, we have 321 beds that are for adult critical care, medical surgical, intermediate critical care. So we're at 94% occupancy in those 321 adult acute inpatient beds. 79 of those patients currently have a positive COVID condition. So it's somewhere around 26% of all the patients that are in the adult acute medical center have a COVID infection, and they're in isolation and they're being treated as such. But it is something that the state pays very close attention to in terms of what percentage of our acute inpatients are actually infected with the virus. That number is rising. It just seems like it was about 5 weeks ago that we hit a relatively low point in this pandemic. We only had 14 positive COVID patients in-house, and yet we were still running very close to 90% occupancy. So we had many non-COVID patients in-house. But now we continue to be very full but that percentage and that number of positive COVID patients continues to rise. 2 days ago it was down to 72, yesterday it was at 77, today's at 79. And this was supposed to be kind of the calm before the storm. And we're trying to figure out why do we see so many COVID patients right now? Is this kind of the Halloween hangover? Because although we're probably 4 weeks out, 5 weeks out from Halloween, but generally we start seeing hospitalizations 2 to 3 weeks following a holiday. So we expected that when we got out away from Halloween and before or right at Thanksgiving, it would be a calm period, but then fully expecting that by mid-December, close to Christmas, we'd start seeing that Thanksgiving surge come. But to already be at 79 patients and not yet have that Thanksgiving surge is what really causes us a lot of fear and anxiety right now. With respect, this is kind of the good news. So 79 COVID inpatients in the acute medical center right now, only 6 of them are in the ICU. So the vast majority of our COVID patients we're being able to take care of in our medical surgical areas. And so we have had to create a lot of what we call COVID pods throughout the hospital on different units. An 8-bed COVID pod here. We have a 14 COVID pod on 4 North. We do have 2 South, which continues to be kind of our dedicated respiratory care unit. Many of our COVID patients go there. Many go on 2 North as well. But again, just through early diagnosis, early treatment, and many of the medications that I'll talk about in a moment seem to be working and keeping those patients out of the ICU. We do have 8 of those COVID positive patients that are on ventilators right now. So all 6 of them that are in the ICU are ventilated, and then we have a couple other patients outside the ICU that are on vents as well. We only have 5 medical surgical beds that are currently open. We don't have a single intermediate critical care bed that is open. And fortunately, the area that we have the most beds open is in ICU. We have currently 15 of our 41 ICU beds are currently open and available. It was handed to me when I just walked in this morning that apparently Governor Newsom has issued stay-at-home orders on a regional basis across California. And one of the trigger points, one of the key trigger points, is what percentage of your ICU beds are available. The trigger point in the governor's order is 15%. So when you get to the point that only 15% of your ICU beds are available, then that's when the regional shutdown occurs. Well, we are currently running, somewhere in the 30 to 40% of being available. So above that 15%, but it's really going to depend on what the governor defines as a region. If it was just Tulare County as a region, our critical care ICU bed occupancy would actually be doing pretty well, but it appears that there are going to be only 5 geographic regions across the entire state. So it could be that the Central Valley is defined as a region that would pick up Fresno and Bakersfield. Maybe it'll stretch as far north as Merced, but then would look at what is the total ICU bed capacity in that entire region. And we definitely see that Fresno is experiencing a pretty severe resurgence in its virus, and actually has a high percentage of their patients are in critical care. Let's see. Oh, the last thing, definitely we've seen, unfortunately, a rise in the number of our own employees that have contracted the virus. We now, through the course of the pandemic, we've had 525 of our employees that have contracted the virus. The vast majority of them have effectively recovered, some with lingering effects, but definitely more have recovered than not. But we currently have right now 102 employees that are currently positively infected and are quarantining at home. We have 19, or we've had 19 physicians and advanced practice providers that have also tested positive since the pandemic, and we currently have 4 of our providers that are out on quarantine right now. Just like the rest of the state and our community, our employee exposures, which pretty much is all community transmitted. Our employees also, go home and they do gather for holidays, and they do subject themselves to exposure. And just in this last week, we had 65 employees that tested positive just in a single week. And I think that's probably the single largest outbreak of our employees that in a single week that we've experienced throughout the entire pandemic. So we continue, just like the community, really encouraging our employees to practice the same very safe habits that they do while they're at work, to do the same when they're at home. So we need them to be safe, we need them to be healthy, so that we can take care of our community. So those are the numbers, Deb.
All right, well, Gary, I have some questions that have come in on the numbers. So, how do we convince somebody who believes that the numbers are being inflated, of the deaths and of the positive numbers? I remember this came up several months ago, and I believe you were asked if the state was counting tests multiple times. And I don't want to get into any kind of political hubbub, but how are you confident in the numbers that the state is putting out?
Well, I'm very confident in our numbers, we have no reason not to be totally honest and forthright and forthcoming with our community. But obviously, it takes not a leap of faith. But it does. You have to place your trust and confidence in us that we're being truthful and honest. And there's definitely for political or other reasons, there might be motivation to inflate the numbers. My intention is not to frighten the community, into embellishing the numbers. We are being entirely honest and truthful, and I think one way to kind of validate that is you look over the course of the pandemic. When it was only 14 patients, I was delighted to tell you that it was only 14 patients, and when it was 91, it was sobering. But we're gonna share the good news with you. We're gonna share the bad news with you. We can only control our data here at the local level. We have had a number of conversations with the county around making certain that they're only counting that one positive test, because patients do get tested, not much less today than they used to. Back in the early days, just out of fear, we would test patients multiple times, a lot of times because we didn't necessarily trust the results. But that's kind of died down now. But when a patient is tested more than once, we only count that one. And the county has assured us that they only count that one, and that's what they're reporting to the state. So I can't speak conclusively for the state or the county, but I can tell you can trust Quia Delta's information.
Okay, so of that, the 26% new COVID patients that we have, were they COVID positive before they came to the hospital? And did they have antibodies? The question's a little bit confusing.
Yeah, so they're not new cases necessarily. In fact, I was trying to get just the most current. So we have 79. So I have 296 patients, adult patients that are in the Acute Medical Center right now. 79 of them are COVID positive. So that's 26.7%. So 27%. It ticked up slightly. So 27% of the patients that are currently in the acute medical center are COVID positive. So they're not necessarily new. Some have been newly admitted over the last few days, but some have been here for some period of time. So it's just looking at the 27%. The vast majority, 90-something% plus, tested positive upon admission. Now, people ask me, were they admitted because of COVID? And it's a great question. It's really hard to answer because all the science shows that COVID causes things to happen. So COVID can actually contribute to heart disease or heart malfunction. COVID's been linked to causing heart attacks, to causing strokes, causing pneumonia, respiratory failure, atrial fibrillation. That's why when we talk about the underlying comorbidities of patients with COVID, is hypertension is number one. Roughly 70% of the patients that are admitted into the hospital with COVID also suffer from hypertension or diabetes, congestive heart failure, obesity. So they could be admitted for congestive heart failure, pneumonia, stroke, heart attack, but they're also COVID positive. And so I'm just reporting the percentage of our patients that are in the hospital that are COVID positive. A good number of them are admitted with a primary diagnosis of COVID. They were at home, their symptoms got worse and worse, they had great difficulty breathing, and so that's what brought them to the hospital, and their primary diagnosis is COVID. But there could be patients that are here with COVID that wasn't really what caused them to be admitted. Now, a patient also could be admitted that tests negative for COVID or shows no symptoms of COVID, but then a few days into their stay, they start exhibiting COVID-like symptoms. And we test them, and now they're positive. And so that's one of the difficult things about this virus, is that once your exposure does not mean that you will immediately test positive. It generally takes 2 to 5 days before the virus builds up sufficiently in your body where it's now detected by a COVID test. We call that the viral load. So that's always that's the frustrating part of it, is we could test somebody and they test negative, but they're actually positive and they are contagious. And in a few days, they will then potentially start showing symptoms. And even if they don't show symptoms, they could now test positive. So it's hard to tell, have patients contracted the virus from the hospital. We call that a hospital-acquired infection, that they were not infected when they came into the hospital, but somehow they contracted the virus from a visitor, another patient, or one of our healthcare workers. So it's really hard to make that determination. We feel very confident that through our protocols, our personal protective equipment, just everything that we do, that we have significantly reduced the risk that a patient would contract the virus in the hospital. But I can't say with absolute assurance 100% that would never happen, because it can.
Right. So with this uptick in employee numbers, Gary, are we having any staffing concerns?
Yeah, we are. That is our biggest challenge right now. When you're at 94% occupancy, that's a challenge to staff. Just by itself. In 2017, when we had a very, very severe flu season, and we put up tents and we literally had patients in hallway beds, staffing was very, very critical, and we were using upwards of 100 travelers. But today, and I talked to a lot of CEOs across the state, that is the number one challenge for hospitals right now, is lack of staffing, particularly among nurses. Unfortunately, there are nurses that the virus accelerated their decision to retire. There are nurses that might be living with an immunocompromised child or parent, or and simply have taken a leave of absence because they don't want to risk exposure. That's compounded by having 102 of our own employees that are infected and out on leave. Last week we had, or the week before that, we had 37 employees that had brand new, COVID infections, and 25 of those 37 were frontline nurses that are now quarantined. So that just puts even greater pressure on us. So we certainly, we're exploring everything we possibly can do. We rely a lot on our existing workforce, offering, financial incentives for them to work extra shifts. But that can only go so far. They're exhausted. They've been at this for 9 months. Just today, we made a decision that even our part-time staff that might only normally work, maybe 2 shifts per week, we were only providing this incentive shift, or this extra shift incentive, which is $400. So a nurse that normally works 3 shifts a week, if they work a 4th shift, a 12-hour shift, not only are we going to pay them time and a half for those 12 hours, but we're going to pay them a $400 bonus for each and every extra shift they take. And bless our nurses that are doing that. We have some that they invest an incredible amount of time, and we're so grateful to them. But we weren't offering that to our part-time nurses, but now starting today we will. So if a part-time nurse who normally worked 2 12-hour shifts a day is willing now to work a 3rd 12-hour shift, then we're going to pay them that extra shift incentive as well. It's almost become a bidding war out there in terms of trying to secure nurse traveler support, because there's just so many nurse travelers to go around, and so hospitals again are all in the same boat, but we're trying to inch up that rate that we'll pay for travelers, and unfortunately the starting salary for a nurse it keeps going up. It's kind of like supply and demand, and so we're feeling that pressure that nurses leaving us to go someplace else for $3, $4, $5 extra an hour. So it's really it's the 1-2 punch when hospitals are in such dire financial straits right now, and at the same time are having to expend more and more and more to keep the workforce intact, and no funding coming from the state whatsoever, and the federal stimulus funds have pretty much stopped right now. So it's just going to continue to make it tougher for hospitals.
Okay, thank you, Gary. So let's talk about the new drug for treating COVID. So, and I'm going to butcher this, so feel free to jump in. Bamlanivimab.
Bamla. Yeah, it's called Bamlanivimab. Bamlanivimab.
We refer to it as BAM.
We do call it BAM. Yeah, we call it BAM.
Are we using it?
We haven't started infusing it yet. We do have it in our possession. It's much like remdesivir, which is an antiviral medication, but remdesivir initially came to us through the federal government, being allocated to the state and allocated to the county health department and then to us. So Bamlanivimab, or BAM, is similarly coming to us through the feds and then to our local health department and to us. And it is a monoclonal antibody treatment. So unlike remdesivir, that is an antiviral medication that is generally given to patients that are in the hospital. You are hospitalized with COVID. So remdesivir has proven effective in shortening the length of stay and decreasing the severity of symptoms of hospitalized patients. Bamlanivimab is an antibody treatment that is given to outpatients, not inpatients. And it's only given to a select number of outpatients. So it's an emergency use authorized drug from the FDA. So this is an off-label use of that monoclonal antibody, not normally used for COVID. And there's still a lot to be known or learned about this drug. But generally, it's recommended for COVID positive patients in the outpatient setting that are at highest risk of being hospitalized. So they are immunocompromised, they have uncontrolled hypertension or diabetes or all those underlying comorbidities that we talk about hospitalized patients. Those patients that have not been hospitalized but they are positive, and you have to have a positive PCR-based test to prove that you're COVID positive, but that if you also are considered at high risk for potential hospitalization, then you're a great candidate for that drug. The drug is infused, meaning it's intravenously given. It's not a pill or a shot. It requires a 1 hour infusion, and we would probably normally do it in our outpatient infusion center. But we are making arrangements now to use an inpatient bed or two to infuse these outpatients in an inpatient bed in the medical center, where we would have, immediately available any emergency services, or if somebody was to, have a severe reaction to that we would have the medications to reverse any type of reaction to that. So, and it's believed that that by giving that medication, that it can prevent that hospitalization, that it can greatly reduce the severity of the symptoms that somebody is experiencing. It has been approved to be used on both adults and children that are aged 12 years or higher. So it has been approved by the FDA. It does essentially, it produces, it's a man-made, it's constructed or manufactured in a laboratory, and it basically creates a protein that causes your body to have an immune response to it and to create your own natural antibodies to fight the COVID virus. So what it essentially does is it stimulates your own antibody production, and it decreases the severity of the symptoms, so that it allows your own body time to build up its own natural immunity or antibodies to start then attacking the COVID cells and destroying them. So it's very promising. There's a few other, Regeneron is another monoclonal antibody. Works very similar to the bamlanivimab, and pretty much, it can be used the same. I don't know which one of those drugs were given to President Trump, when he was diagnosed with COVID, but he received one of those antibody treatments. So James McNulty, who's our director of pharmacy, he's been working with our medical task force to create the criteria under which we would provide that to a patient. And again, we have that medication in stock now and expect to be using it quite soon.
Okay, so moving right into like medications or vitamins, is there anything that other people can take to maybe avoid being hospitalized if whether or not they're recuperating from the virus or whether they're just trying to prevent getting the virus. Do you recommend any regime or any certain vitamins or medications?
Yeah, and again, this is just my own personal research, but also talking to, our physicians and our clinical staff. And it's a question that I had been asked kind of early on in the pandemic, and our recommendation as a healthcare institution is, eat foods that really will boost your own immune system, and do things that will also boost your natural immune system. So when we talk about vitamins, vitamin C, vitamin D, zinc, other vitamins that have been known to enhance or boost your immune system. I know that a lot of folks are taking those medications. Again, it doesn't prevent you from contracting COVID, but it can elevate the responsiveness of your own immune system to fight that virus in the event that that you should contract it. But we also talk, lots of healthy fruits and vegetables that are good for you health-wise, as well as boost your immune system. Getting lots of sleep, or definitely not being sleep deprived, and exercising, drinking lots of water, staying hydrated. All the things that are normally, good for us anyway. And I don't know if you do them, in extra quantities, but those are definitely the things that most, clinicians out there are recommending to potentially help ward off, you contracting it, but more so just so that you'll be a lot more effective in responding to it.
Okay, thank you. So let's move into the topic of the vaccine. And before we get into when we're going to receive it and how we're going to roll it out, can you address some rumors that have been sent in regarding the safety of the vaccine? You have said several times you have confidence in the safety of the vaccine. So a couple of rumors that we heard this week out in the community. One is that because it's a synthetic vaccine and it's not the live virus, that it's a way to implant a chip as a tracking device into people, to be able to track who's had the virus, to be able to track who's received the vaccine. And then another one that we heard this week was that the vaccine is comprised of cells from aborted fetuses. So can you just kind of address those if you have any knowledge on those rumors?
Yeah, well, I could not have addressed those yesterday, but I can today. And I appreciate the complexity of the questions that are posed to us, because it definitely has made me so much more knowledgeable in this area, just doing the research, preparing for this. But it might have caused me to chuckle at first. That might have been my first reaction. But as I did the research, I see it's actually grounded in facts and circumstances that would cause somebody to feel that way. So with respect to the first rumor about the microchip, and people reference Bill Gates, in that same discussion. So as I researched it, there's no doubt about it that Bill Gates and the Gates Foundation has supported research that is aimed at documenting and tracking vaccinations, primarily in third world countries that have less access to vaccines. And he has wanted to create a more robust tracking and monitoring system to determine people that have been vaccinated, those that have not been vaccinated. So there actually is research that is going on right now to develop technology that would essentially replace a syringe that we normally think of administering a vaccine. So this is a different type of device that is not implanted on the skin, but like a shot, it is pressed into the skin, and it punctures the skin, and it administers the vaccine, but it leaves behind kind of I'll say a tattoo of sorts. It's not viewable by the naked eye, but you can scan a smartphone or other device across it to see if that person has been vaccinated or not. It does not leave any microchip or anything of that nature in the body, under the skin. It literally is just kind of I'll say an ink imprint. And the reason behind it is, again, to be able to quickly know if a child or an adult has been vaccinated, or to prevent a child or adult from being vaccinated more than once for the same virus or disease that we're vaccinating against. So Bill Gates is funding that research and that technology, which may be why this was associated with him. Again, there is no microchip in any of that research, and that technology is not yet being used. It's still being studied, but it has not been deployed anywhere else. There is likelihood, and maybe this has already been concluded, that the syringes that will be distributed will have a microchip on the outside of the syringe that will allow us to track where and when the COVID vaccine has been administered. But it will not be actually in the vaccine. And the smallest RFID, radio frequency identification device, or microchip that exists today, I think it was developed by IBM, is the size of a grain of salt. But that grain of salt would be clearly visible in a vaccine. So what I've read is, the likelihood that so many people, are involved and supporting, all the way from the scientists and the manufacturers and the doctors and nurses that administer the vaccine, that would clearly see that there's something in the vaccine that isn't the vaccine, would be administering it. So I do now appreciate why folks were thinking that, but there seems to be no evidence whatsoever that a microchip or any type of monitoring or detection vehicle would be in the vaccine itself and injected into the body. But there definitely are efforts underway to be able to at least determine who's had a vaccine or not. And so that's what I've learned about that piece. The use of aborted fetuses in the manufacturing of vaccines, and COVID-19 vaccine in particular, is a really interesting subject, and again is founded in facts, because there actually are a number of vaccines: measles, rubella, chickenpox, rabies, that actually have been developed using what are called descendant cells of aborted fetuses. But they actually relate to specific fetuses that were aborted back in the 1960s and 1970s. And that's where the term descendant cell comes from. So what's being used in current vaccines are descendant cells, not cells of recently aborted fetuses. And there are certain COVID-19 vaccines that the pharmaceutical companies, the scientists, are using some of those descendant fetus cells to develop their vaccines. Moderna and Pfizer, which are the two vaccines that are about ready to be released, they're the messenger ribonucleic acid, or mRNA, vaccines that are manufactured in a laboratory. Neither of those vaccines use aborted fetus cells or even the descendant aborted fetal cells. And the Catholic Church has come out specifically and acknowledged that they don't. That those two vaccines do not have any relationship whatsoever to aborted fetus cells. Now that said, I don't know if it was Moderna or Pfizer. I think I do have that. That did in fact, as part of their proof, okay, oh yes, in fact it says, early in the development of mRNA vaccine technology, fetal cells were used for proof of concept to demonstrate how a cell could take up mRNA and produce the SARS-CoV-2 spike protein. So they were used as part of the research and testing, but that's the only time they were used. They were not used in the actual production of the vaccine. They are not in the vaccine itself. And there's a quote here, says, the Pfizer and Moderna vaccines were found to be ethically uncontroversial by the pro-life policy organization, the Charlotte Lozier Institute. Further, Brian Kane, Senior Director of Ethics for the Catholic Health Association of the United States, in an interview for the America the Jesuit Review, stated, in terms of the moral principles of being concerned about the use of any pharmaceuticals that were developed from aborted fetuses, that is certainly an issue that we all want to be cognizant of and try to avoid their use. With that in mind, the Pfizer and Moderna COVID vaccines that are coming out are not even tainted with that moral problem. So I now understand where that concern has come from, and I spoke to somebody this morning that remains concerned, ethically, morally concerned, because the aborted fetal cells, again, descendant cells from more than 40, 50 years ago, that those descendant cells were used in the study of these vaccines. So even though it's not in the vaccine, the fact that they were even used in the original study and creation of the vaccine does cause people understandable concern.
Right, okay. So we're getting ready to start rolling out this vaccine. When do you think we will receive it?
So Pfizer is expected to receive its EUA approval from the FDA on December 10th, and Moderna is expected to receive it on December 17th. And we actually expect that the vaccine will be shipped within hours of receiving that approval. We understand that California will receive 370,000 of the initial dose, and it's all to be used to give that first dose. And then 21 days later, we will receive another 370,000 to give the second dose. So there are only 370,000. There are 2 million frontline healthcare workers in California, which have kind of been designated as the first recipients of that vaccine. We already are making arrangements. We're converting one of our conference rooms right now in the Visalia wing into our vaccination station, where we will start vaccinating. Again, James McNulty and our medical committee are already going through the decision tree in terms of who we will initially vaccinate and how we will do that, how we will monitor it to make certain that 21 days later, we want to make certain those people that got the first vaccination get that second one. It's also interesting, pretty much is believed that people will have the same reaction as to the shingles shot. It has a very powerful immune response. I got the shingles shot for the first time. I was sick as a dog for 2 to 3 days after with what felt like very severe flu-like symptoms. I got over them quickly, and the pharmacist said, well, you had a great immune response, Gary, so that's what we want to see. Not everybody has that, but they say more than 50% of people that get the shingles shot will have that reaction. They're believing that a similar number of folks will get the same reaction from this COVID vaccine. So you don't want to, come through and vaccinate an entire department, vaccinate all your nurses on 2 South, because you're going to wipe out them, for a couple days. So that's whole part of that logistical process.
And I want to kind of throw in here, Gary, because our employees are also a little concerned. So nobody is being forced to take this vaccine.
That's correct. Unlike the flu vaccine, where a number of years ago we did decide to make it mandatory, pretty much followed the same path that every hospital across the nation had taken. We do, for medical reasons or other exceptions, we have historically allowed somebody to wear a mask throughout the entire flu season and not get vaccinated. But the vast majority, in the high 90% of our employees, get the flu vaccine. But we will not mandate it for the COVID vaccine. A study that just was released, I think yesterday, among physicians, it sounds like 50% have indicated they will get the vaccine, but among other healthcare workers, it's a third that will get the vaccine, a third that won't get it, and a third that are undecided. So it will be interesting to see how that plays out here locally.
Okay, so we have several questions left that we're going to run through quickly. We are running out of time, but we're going to keep rolling just to get these questions answered. So if you guys have to sign off or leave us for any reason, thank you so much for joining us, but we're going to keep going. So Gary, the recent all facilities letter was sent by the California Department of Public Health, and so it is mandating that we start testing all hospital workers weekly. So is Cahuilla Delta prepared to do this?
So that all facilities letter just came out the Wednesday night before Thanksgiving. So it's being recently released. It really kind of came as a bit of a shock, certainly an unknown direction that was coming to us. The AFL, again, all facilities letter that comes from the California Department of Public Health, it has language in there that it says it's strongly recommended. So it's not being mandated by the state, but strong recommendation generally shortly precedes mandated. We are mandated to submit a plan to CDPH. I think it may be by tomorrow or at the latest Monday the 7th. But it has to reflect what our plan is. Do we intend to follow the AFL? I think our belief right now is we will. There is discretion that's being given to us in terms of who are we going to test weekly. Is it just going to be frontline employees who have patient contact, physicians who have patient contact? And we have 5,000 employees. We have 1,200 nurses, probably 3,000 frontline healthcare workers when you think about LVNs and CNAs and respiratory therapists and so forth. So we're going through that ever since that letter came out. We've been working on that. John Knudsen, one of our director of critical care services, kind of leading that initiative right now. The biggest concern from hospitals, a hospital like Cahuilla Delta, we have the testing platforms and the testing supplies to be able to do it, but there are many hospitals throughout California that aren't going to be able to do this. They simply don't have the bandwidth and the supplies to do it. So the California Hospital Association is trying to negotiate with the state, reach some kind of compromise. Also, this is happening on the heels of a vaccine. So the one thing I am pleased to announce is that with respect to all of the testing that happens throughout Aquia Delta, whether you're an inpatient coming through the ED, an employee, in testing in any of our clinics, we've now made the definitive decision that we are now going to move to a simple nair swab in the nostril and no longer do the deep nasal pharyngeal. There is enough evidence that proves that there really is no difference between the results using. You still want to get a really good swab in the nostril, particularly those patients that appear to be asymptomatic. But that will be, I think if you told our employees every single week we're going to do the deep nasal pharyngeal, they'd run for the hills. So at least that's one positive thing, is moving to that NAERS-based approach.
Okay, perfect. So let's talk about testing a little bit. We've been sending community members and employees to the testing hotline. We had a lot of feedback. People have waited for hours on that testing hotline. Some of them have never gotten through. So what's being done to relieve this backlog, and are there better testing options in the county that we need to start discussing?
Yeah, there's a lot going on, and no doubt about it. And first I want to apologize to all of you that frustratingly have had to suffer through this. You know, on one hand, Aquia Delta wants to be, you know, your health provider, whether, you know, during sickness and injury, but being your health and well-being, we want to be there for you. And so we took on really kind of a bold position to be that. We went out, secured all the platforms. Randy Coca did a phenomenal job securing the Quidel Sophia 2, deployed that everywhere, but never could we have imagined that we were going to have the demand that we did, particularly right before Thanksgiving, when literally vans would pull up with 8-10 family members in the van, all wanted to be tested before they headed off to grandma's or, you know, uncles and aunts and stuff. So that really just overwhelmed us. It overwhelmed our call hotline, and we were just understaffed for it. At the same time, we also, some of those staff, contracted the virus themselves. So here we were short-staffed, overwhelmed from a technology standpoint. So a decision was made this week that beginning on Monday, we will no longer accept walk-in folks that just walk up to be tested. However, on Monday, if you go to the Aquia Delta website, there is a page there that will let you look at every single one of our testing sites. So our 2 urgent care centers, our 3 rural health clinics, our family medicine clinic, Visalia Medical Clinic, Sequoia Prompt Care. There will now be using a platform called Clockwise. It will allow you to schedule your COVID test, and you will see exactly what time. It'll allow you to schedule up to 2 days in advance for 48 hours, but you can click on every one of those sites and see when the most next available appointment is. And we will give you same-day results, but it really has been kind of the walk-ups that have overwhelmed us. So that will be a big change on Monday that we really think is going to have a significant improvement on our testing throughput. We'd certainly, like you to think to us as your first choice, and hopefully the scheduling now greatly improves that experience.
Right. Okay. Thank you. So now that our numbers are going back up, are you reviewing the visitor policy, and are we going to be making any changes to that?
Yeah, we are, and that's kind of what we shared with folks at the very beginning, is that this pandemic is absolutely a roller coaster. 14 and 91 on 2 ends of the spectrum in terms of COVID patients in house, and first and foremost, we're always motivated around keeping our patients safe, keeping our employees safe, our physicians, and our visitors. So it wasn't that long ago that we kind of opened up the visitation, going from 8 a.m. to 8 p.m., allowing a visitor to be there all day, and even allowing a second visitor the next day, a different visitor the next day, and a different visitor the day after that. So just what we're experiencing and what we're expecting to experience in the next 2 weeks, we are exploring potentially restricting that. but we still want to allow visitors. So it probably will be on a more limited basis. We're really leaning towards just one unique visitor throughout the patient's entire stay, as opposed to allowing a different visitor each day. Most likely we won't go 8 to 8. That will have, maybe a 2-3 hour window in the morning, a 2-3 hour window in the evening. With respect to surgery, right now we allow the patient and a visitor to come into the surgery waiting room to get registered. When the patient's brought back to pre-op, we allow the visitor to go back to pre-op. We allow the visitor to go back to post-op after they come out of surgery. We probably will no longer allow a visitor to go into pre-op and post-op, but will allow them to sit with them in the waiting room. And then when they're taken back to pre-op, the visitor will stay out in the waiting room. We won't make them return to their car, and that way they can review the big board that shows, not the name of their loved one, but a number that allows them to watch how their loved one is moving through the operative process. But then certainly if a surgical patient is admitted after their surgery, then we would allow that patient or that visitor to come visit their patient again within those the window of those hours, and again it would have to be that patient's designated unique visitor. So it's not finalized yet. We probably will have something finalized, if not by tomorrow, by Monday, and then start rolling that out pretty quickly.
Okay, thank you. So at the beginning of the pandemic, we really experienced PPE shortages. And in fact, it was kind of, an emergency and frantic time for us. What is our status of PPE at Cahuilla Delta right now?
Yeah, without a doubt, it is greatly improved. Although we still are struggling for gloves and gowns. Those tend to be some of the areas that we've had the most prolonged shortages. But the availability of masks, both N95 masks and surgical masks, has significantly improved. We have currently about 350,000 N95 masks. We actually were working towards building an inventory of 500,000 N95 masks. And if we could get to that level and feel confident and that it would be constantly replenished, we were actually going to move to what we call a single use of that N95 mask, meaning that a nurse would put on a new fresh N95 mask when they walked into the patient's room, and then when they walked out they would throw it away, and just do that throughout the day. We would burn through thousands and thousands of masks every day, but as long as the supplies kept coming in, we were prepared to do that. But just about a week and a half ago, 2 weeks ago, when we hit that 350,000 level, the supplies started drying up. And so our distributor pretty much ran out. I don't know if that's improved yet today, but because it has, we're not ready to implement that single use. But we do absolutely give a fresh N95 mask to a clinician each and every day. We're not requiring any more reuse over a period of time.
Okay. So is the Department of Defense going to jump in and help us if we run into the same problem we did in our July surge?
We would certainly welcome them back without hesitation. They were amazing people at a time when we really could use them. But we haven't heard any word since then. I've certainly heard it discussed, but we have not been contacted by the Fresno EMS system. Dan Lynch is who first contacted us from Fresno to let us know that the cavalry was arriving, but have not heard anything since then. But again, we'd certainly welcome them back. There was an interesting article in the paper today about the state's health force. Early on in the pandemic, the state announced that they were putting together a team of almost 100,000 retired healthcare workers, nurses, doctors, therapists. They were going to create this, not a space force, but a healthcare workforce that could be deployed to hospitals throughout the state to help them supplement their staffing. And the article, or the headline was, what happened to the state's workforce? Because less than 1% of those 100,000 people actually ever joined the workforce. Virtually all of them were ineligible to provide that care, and so there pretty much is no state workforce available to us. So we're pretty much on our own.
Okay, thank you. So final question before we go into some comments. With the increase in numbers, are we going to stop having in-person community engagement meetings at our facilities?
Yeah, I think I heard from you, Deb, that we've decided, at least for December, that we're going to go back to virtual. I did just a few weeks ago. It was wonderful. Our community advisory committee on the Hospital of the Future, which I chair, we met in person. We met over at the Lifestyle Center, and everybody spread it out and wore a mask, and only boxed lunches for those that attended in person. We had others that attended through GoToMeeting, but it felt good to see people again. But with this resurgence, again, first and foremost, we're concerned about the health and safety of our community, and particularly not particularly, but definitely our
we like our community engagement.
We do like them a lot, but you can't have a favorite son or favorite daughter, so we like our whole community. We really do appreciate our community engagement folks and want to keep them safe and healthy. So we're going to have to kind of play it by ear, but I think for December we've decided GoToMeeting only.
Okay, thank you. So do the county leaders in Tulare County, do they meet with Cahuilla Delta regularly to get updated? Because somebody chatted and said, are we seeing increases due to the result of our county leaders not fully enforcing the masks?
We don't meet with them physically, but we have. I think I've shared with you that I participated in probably 3 press conferences where the county, myself, the sheriff, Amy Sheklian from the Board of Supervisors, Tim Lutz, that we've all been there communicating, sharing information with our community, imploring them, to practice good behaviors. We do have almost regular weekly meetings. Annette Burgess of the County Health Department, Tim Lutz, occasionally Dr. Hott. We do have those regular meetings where we're sharing information and things of that nature. Actually, interestingly, this week, Tim Lutz reached out to me. He's the director of the Health and Human Services Agency for the county. And the County Board of Supervisors has asked me and Donna Hefner, the CEO of Sierra View Hospital in Porterville, if we would come to their next meeting on December 14th and provide the Board of Supervisors kind of a comprehensive briefing of what we're experiencing at the local hospital level, and to give them an opportunity to ask questions. And so that dialogue is ongoing. And I think you've seen that the sheriff and the police, and they're not in the business of enforcing mask wearing and enforcing behaviors. That's not their priority in protecting the health and safety of our community. So I think we've kind of looked to our residents to self-enforce, and I know that's incredibly hard, and especially when we get into the holiday season. For some folks, it's already kind of a depressing time to begin with, and now to be shut down. I mentioned earlier, Maria just slipped under my nose here. Gavin Newsom announces new stay-at-home order tied to ICU capacity. And apparently our region is defined as the San Joaquin Valley. So it includes Calaveras, Fresno, Kern, Kings, Madera, Mariposa, Merced, San Benito, San Joaquin, Stanislaus, Tulare, and Tuolumne. And so if our collective aggregate ICU capacity across all those counties falls below 15%, meaning we're collectively 85% full, and that could mean Quia Delta's empty, but these other counties are full, and together it pushes us up to that 85%, we all get shut down. Now, I haven't read the whole thing to see what does stay at home exactly mean. We're pretty much, we do have outdoor dining right now under Tier 1 Purple, but that goes away under shelter at home, and so now you have takeout only. So that would be a change for us. I don't know. It's where our region is right now. So that's an interesting fact. I need to find out. How close are we to 15%? Quia Delta is not close. In fact, what did I indicate that we have? Sorry, do my math real quick.
Yeah, we were doing good.
Yeah, 22 of. Oh wait, no, that's no 19 of 41. So we have 46% of our ICU beds are open. So we're a pretty long way away from 15%, but I don't know where we are from a regional standpoint.
Okay, so just a couple of comments. Another vaccine rumor that the vaccine will change your DNA. So we didn't research that one, Gary, but maybe we'll look into that.
Yeah, yes I did. Yes I did.
You did?
I did.
Okay.
Yes. I think it might be. Maybe it's not on here. No, I did. I read that exact same question, and these two particular vaccines, the messenger ribonucleic acid, the mRNA, RNA does complement our DNA, but according to the research I read, that very question was asked, that concern, and the comment was that unequivocally neither of these two mRNA vaccines change the DNA. In fact, the way they're designed and how they perform, they're incapable, physiologically, biologically, whatever, incapable of changing somebody's DNA. So again, I'm relying, trying to go to websites or authors that I have confidence in. That's what I read just this morning.
Right. Okay. Thank you. So Pastor Lefebvre, he was obviously on that Governor Newsom update. So he says it's a 3-week shelter at home. Retail is at 20% capacity. Hair and nail salons are closed. It will be food takeout and delivery only. Schools with waivers can stay open with guidelines, and religious services can stay open under purple guidelines. So thank you to all of you who are chiming in with information. And Gary, I think we have answered all of the questions, and someone chatted, thank you so much for all of this valuable information. So I'm going to let you close.
Yeah, well, thank you for staying late with us. I really appreciate it. It's good to be back in front of you, and it's nice to have a little bit different variety in terms of the questions, and I'm certain that in the coming weeks we'll have a lot more to talk about. But again, thank you for your continued support of Quia Delta. Keep those thoughts and prayers coming our way. We greatly appreciate it, and we really feel they make a difference. So stay safe, stay healthy. Do everything you can to keep you and your family safe through these holiday seasons. So take care.